Someshwar Garu, now we are live, so you can please start.
Yeah, thank you, Savan. Ma'am, with your permission, shall I start?
Yeah, sure.
Yeah. Thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. P. Surekha Vinay, ma'am, who is a obstetrician and gynecologist and consultant at Gauri Gopal Hospital, Kurnool. And she is the director of Gibson Clinic, Kurnool. And her special interests are PCOS, weight loss management, high-risk pregnancy, and menopause. And with this, we welcome you for today's webinar, ma'am. And coming to today's topic, dyslipidemia and PCOS. As we know that there is a predominance of metabolic syndrome in PCOS, which can lead to long-term effects in PCOS. So now, without wasting much time, let me turn over the time to Dr. Surekha, ma'am, to talk on dyslipidemia and PCOS. Over to ma'am.
Okay. Hi, good evening, everyone. Thank you for this privilege of talking on dyslipidemia and PCOS. Let us start.
Dyslipidemia and PCOS. As we all know, PCOS is a multi-targeted disease with so many things yet to be known. Now we are about to know few things about dyslipidemia. PCOS, it's discovered by Steen and Leventhal in the 1930s, described the association between PCO morphology, hirsutism, menstrual disturbances, and obesity, the most common endocrine disorder in women. Coming to the incidence, it's 3 to 10% of women of reproductive age and 25 to 30% of infertility patients. And the major cause of anovulatory infertility, 75% of PCOS infertility is due to anovulation. If you look into this picture, the GnRH hormone, when it is released from pituitary, it releases FSH and LH. In normal case, FSH acts on the granulosa cell and LH acts on the theca cell. In PCOS, there is increased LH and FSH relatively is less. And here the pathology is the insulin acts on the theca cell. The cholesterol metabolites pregnenolone, progesterone, 17-hydroxyprogesterone, becoming androstenedione, and lastly into testosterone, is converted to estrone in the granulosa cell. But in PCOS, the testosterone levels are elevated due to action of insulin on the theca cell. If you look into the pathogenesis of PCOS, it has many parts of it. The genetic predisposition to excess ovarian androgen secretion is the main thing that is happening on the ovary. It leads to increased testosterone levels, which in turn leads to increased LH levels and insulin resistance and hyperinsulinemia. And both these together, they lead to anovulation. The increased LH levels from pituitary gland in turn leads to increased testosterone levels. And the increased insulin levels due to insulin resistance and hyperinsulinemia act on the liver, which in turn leads to decreased sex hormone binding globulin. And the ultimate and the last result is the hirsutism. And one of the genetic and the dietary factors that influence insulin secretion or action is also the pathogenesis in the PCOS. Coming to etiology, complex trait interaction of genetic and environmental factors. It's a two-hit hypothesis. PCOS etiology has a complex trait involving two hits. And the first one is congenital predisposing hit, heritable traits and gene variants affecting ovarian function, heritable traits and gene variants predisposing to insulin resistance, obesity, and type 2 diabetes mellitus, congenital virilization, and disturbed fetal nutrition. And second one is the postnatal provocative hit. Here, there is insulin-resistant hyperinsulinemia leading to metabolic syndrome and postnatal obesity and results in puberty, changes in puberty. The factors contributing to PCOS phenotype. PCOS encompasses a woman's life cycle. Factors potentially impacting the pathophysiology of PCOS. As we look into the picture, the circles, they represent neuroendocrine factors, diet, CNS programming, epigenetic changes, genetic variants, inflammatory factors, environmental exposures, exercise and activity, hormone exposures, ectopic fat storage, androgen excess, adrenal factors, ovarian factors, insulin secretion, and insulin sensitivity. Not all factors affect each individual. PCOS epitomizes a biological network of interacting neuroendocrine, hormonal, metabolic, genetic, and environmental influences. If you look into the picture, all stages of the female, that is, it starts from in utero, adrenarche, adolescence, adulthood, pregnancy. So no stage is escaped from the PCOS changes. As we all know, PCOS is a lifelong disease. It has to one extreme ovarian disease and to the other extreme metabolic disease. Coming to the adolescent age, around 15 years, they present with clinical hyperandrogenism and oligoanovulation. And 25 to 30 years, that is reproductive age, they land in infertility, hyperandrogenism, and pregnancy complications. And around perimenopausal age, there is hyperandrogenism and glucose intolerance. The patients will be under care of endocrinologists, diabetologists, and gynecologists. And coming to the metabolic part of this PCOS, it's in the menopausal age. It has cardiovascular events, type 2 diabetes, and the risk of endometrial cancer. Here again, gynecologists, diabetologists, and cardiologists comes into action. So the gynecologist has a major role throughout the woman's life if she is affected by PCOS. Metabolic syndrome. The risk factors for metabolic syndrome include central obesity, hypertension, atherogenic dyslipidemia, insulin resistance. Metabolic syndrome affects about 33% of women with PCOS. Consequences of metabolic syndrome include cardiovascular disease, type 2 diabetes, cancer, sleep apnea, and psychological problems. Summary of mechanisms linking obesity with PCOS. If you look into this picture, one end is obesity and the other end is PCOS. There is a defect in the fat metabolism, like adipokinase release and obstructive sleep apnea, insulin resistance, and androgen-mediated lipolysis, genetic factors, energy expenditure, and mental and emotional health, and which in turn the compensatory hyperinsulinemia results in ovarian androgen production, leading to dysfunction with anovulation and metabolic dysfunction. So every system is affected by neuroendocrine factors, hormonal factors, genetic factors, and both are interrelated by different mechanisms. Dyslipidemia, that is abnormal lipids, involvement in the development of PCOS. Studies have revealed that there are different degrees of obesity, dyslipidemia, insulin resistance, oxidative stress, and other metabolic abnormalities. And among these abnormalities, dyslipidemia is one of the most common phenomena observed in women with PCOS. Lipid abnormalities are found in women affected by PCOS. A recent study showed that mild hypercholesterolemia is frequently encountered in women with PCOS. Different lipid patterns are present in PCOS. including low levels of high-density lipoprotein cholesterol, HDLC, high triglycerides, total cholesterol, and low-density lipoprotein, LDLC, and significantly higher lipoprotein concentration. So here the low-density lipoproteins, that is bad lipoproteins, are elevated, and dyslipidemia and insulin resistance. Approximately 50 to 70% of women with PCOS also have insulin resistance, and the risk of type 2 diabetes among women with PCOS is 5 to 10-fold greater than that among healthy controls. Up to 70% of women with PCOS have dyslipidemia. Most studies report decreased HDL, that is good cholesterol, and increased triglyceride levels in PCOS, which is the same lipid profile known to be associated with insulin resistance. The study found that the proportion of insulin resistance diagnosis was statistically higher in obese women than in women with normal BMI, suggesting a significant association between insulin resistance and dyslipidemia. Dyslipidemia was found to be related to central fat in obese PCOS patients because the location of the adipocytes in central fat had a disadvantageous effect in plasma. Strikingly, intra-abdominal visceral fat accumulation may contribute to lipid metabolism disorders. The subcutaneous abdominal adipose lipids protect against insulin resistance in humans, but the intra-abdominal tissue has the opposite effect. The dysfunction of subcutaneous abdominal tissue can enhance free fatty acid uptake in non-adipose cells and in intra-abdominal adipocytes, promoting lipotoxicity, potentially explaining the occurrence of insulin resistance even in lean PCOS women. Dyslipidemia and hyperandrogenism. Hyperandrogenism is a vital feature of PCOS patients. A previous study reported that there were no associations between the lipidomic profile and testosterone. In addition, studies have also shown that HDL levels are lower in PCOS patients without hyperandrogenism. Abruz et al. Found that all PCOS patients, independent of their androgenic condition, showed a high metabolic risk. These studies indicate that androgen is bad for lipid metabolism, while dyslipidemia does not directly affect metabolism in PCOS. However, recent studies have produced different results. Gobel et al. Found liver fat to be tightly related to hyperandrogenism and associated with an adverse metabolic risk profile. Hyperandrogenism in normal weight PCOS women is associated with preferential intra-abdominal fat deposition and an increased population of small subcutaneous abdominal adipocytes that could constrain subcutaneous adipose storage and promote metabolic dysfunction. In addition, the women with PCOS present adipose tissue dysfunction in the subcutaneous compartment, which is characterized by an alteration in adipocyte size and leptin-adiponectin expression and secretion, most likely associated with higher androgen concentrations. These findings suggest that hyperandrogenism is associated with fat distribution. Reduced apolipoprotein A1 levels have been observed in the serum of PCOS patients, and apoprotein A1 knockdown reduced the number of transcripts of steroidogenic enzymes in a human ovarian granulosa cell line, while apoprotein A1 overexpression generally increased the expression level of these enzymes. A reduced CYP19 expression level due to apoprotein A1 depletion may subsequently impede the conversion of testosterone to estradiol, potentially partially accounting for the higher testosterone levels observed in PCOS patients. Coming to dyslipidemia and oxidative stress, that is inflammatory origin. Adipose tissue as a source of pro-inflammatory cytokines has the capability of secreting angiotensin II which stimulate NADPH oxidase activity. Thus, NADPH oxidase is a major route for ROS production in adipocytes. In addition, the increase in free fatty acids in PCOS stimulates NADPH oxidase expression and subsequent ROS generation, further promoting the insulin resistance observed in obese women with PCOS. Several studies have found that patients with PCOS have significantly higher levels of CRP and that lipid levels are correlated with CRP levels. Higher levels of inflammatory markers such as interleukin and tumor necrosis factor A have also been reported in PCOS patients compared with those in a control group. TNF-A and interleukin are associated with an increased risk of cardiovascular disease, atherosclerosis, dyslipidemia, and hypertension. Lipid-lowering therapy was found to be effective in lowering markers of inflammation. A relation between dyslipidemia and anovulation. Anovulation has been found to be related to dyslipidemia and PCOS patients. A study found that women with anovulatory PCOS have higher total cholesterol, triglycerides, and LDL-C concentrations and lower HDL-C levels than women with ovulatory PCOS. Obesity could lead to dyslipidemia, irregular ovarian cycles, and anovulation in women of reproductive age. A study showed that high levels of triglycerides, free fatty acids, and oxidized LDLs in serum resulted in mitochondrial dysfunction with augmented release of ROS, in turn leading to ovarian damage and an increased rate of follicular atresia. Lectin-like OX-LDL receptor 1, Toll-like receptor 4, that is TLR4, and cluster of differentiation 36, CD36 and OX-LDL receptors, and the OX-LDL dependent activation of these receptors can result in apoptosis of human granulosa cells and disordered ovulation. In addition, abdominal obesity stimulates ovarian and adrenal androgen production, whereas SHBG levels are reduced in PCOS. High testosterone levels may further increase abdominal obesity and inflammation, creating a vicious cycle in PCOS. Lipid metabolism is involved in changes in the PCOS oocyte environment. Significantly increased levels of glycerol and lipid region, cholesterol, and a slightly higher level of lipids LDL have been observed in PCOS follicular fluids than in normal control follicular fluids. Moreover, levels of free fatty acids such as palmitoic acid and linoleic acid are increased in PCOS. These changes suggest that dyslipidemia influences the development of follicles in PCOS, which results in infertility. If you look into the picture, the influence of lipid abnormalities in PCOS. There are two colors of arrows, three colors, black, red, and green. The red into here, there is no conversion of testosterone into estradiol. And coming to the monocysteine HDLC, free fatty acids, apoprotein A1, and OX-LDL, their role is, it results in inflammatory markers which leads to inflammation in PCOS. And here the NADPH released from free fatty acids, in turn releasing reactive oxygen species, leading to insulin resistance in PCOS. And in the cholesterol ester uptake, there is a conversion of these proteins, CYP in 11, 19, HSD, and 3-HSD, converted into testosterone. And here there is no conversion into estradiol, so hyperandrogenism leading to PCOS. And the LDL receptors at the mitochondrial level, ROS are released, leading to follicular atresia and ovarian damage, leading to anovulation in PCOS. So dyslipidemia causes inflammation, insulin resistance, hyperandrogenism, anovulation, all together becoming a part of PCOS. Therapeutic effects of lipid lowering drugs on patients with PCOS. There are three categories of drugs acting in dyslipidemias. One is statins, and second is omega-3 polyunsaturated fatty acids, and the third is nicotinic acid. Statins are the proven and the oldest method of treating dyslipidemias for prevention of heart diseases. Here the cholesterol synthesis is affected, and statins act by improving hyperandrogenism. It acts on 25-hydroxy vitamin D, improving the irregular menstrual function. And these statins also have an effect on decreasing homocysteine levels, which in turn improves insulin resistance. Coming to the omega-3 polyunsaturated fatty acids, these act on the cholesterol metabolism. There is inhibition of protein kinase enzymes and decrease in LDL values, increase in HDL values. There is absorption of fatty acids decreased in liver. Triglyceride uptake is decreased so that it improves dyslipidemia. And the SHBG, which is decreased in PCOS, is improved by omega-3 acids, and there is improved hormonal profiles. And coming to nicotinic acid, it inhibits the hydrolysis of total triglycerides, hepatic synthesis and release of VLDL triglycerides, improved dyslipidemia. Here the bad cholesterol's LDL levels are reduced, the uptake of triglyceride is reduced, and there is improved dyslipidemia. Statins. If you look into the role of statins, they act both ways. That is, they act on insulin resistance and hyperinsulinemia, and also they act on oxidative stress and systemic inflammation. When they act on the insulin resistance, there is thecal hyperplasia, increased androgen synthesis is stopped, so that the hyperandrogenism and the anovulation are corrected. Coming to the oxidative stress and systemic inflammation, they act on the endothelial dysfunction, act on dyslipidemia, and there is prevention of cardiovascular disorders. Statins are commonly used to treat PCOS patients to reduce inflammation, oxidative stress, hyperandrogenemia, and other metabolic parameters. Statins have been reported to block HMG-CoA to inhibit the synthesis of mevalonate, which is a necessary substrate for cholesterol synthesis and can be used to synthesize other important lipid intermediates. Therefore, statins can improve lipid status and hyperandrogenism. A recent study found a decrease in total cholesterol, triglycerides, LDL-C, and an increase in HDL-C, accompanied by a drop in insulin resistance after treatment with statins. After treatment with atorvastatin, the concentration of 25-hydroxy vitamin D in PCOS patients increased significantly, which improved symptoms for PCOS patients with irregular menstruation by reducing C-reactive protein. Statins significantly reduce malondialdehyde, MDA concentrations of oxidative stress markers and free testosterone, while plasma levels of MDA are positively correlated with total testosterone and free testosterone, which suggests that the reduction in androgen may be associated with plasma MDA levels in PCOS patients. Thus, statins can improve lipid abnormalities, inflammation, oxidative stress, and hyperandrogenism. All these are a major part of PCOS. Atorvastatin, simvastatin, and lovastatin are the most common statins and can inhibit DNA synthesis and growth of follicular mesenchymal cells. Simvastatin is the most potent of the three. Simvastatin can improve menstrual cyclicity and reduce hirsutism, acne, and ovarian volume. and a decrease in ovarian volume likely occurs in parallel with a reduction in the number of Theca cells after simvastatin treatment, resulting in decreased androgen production. Simvastatin can inhibit proliferation of follicular mesenchymal cells and reduce the expression of CYP17A1 and the production of androgen. Compared with simvastatin, atorvastatin significantly reduces homocysteine levels in plasma and improves insulin resistance. Homocysteine levels in plasma are associated with insulin resistance. Therefore, the improvement in insulin resistance is related to the change in homocysteine levels in plasma. In addition, atorvastatin and simvastatin can reduce free testosterone and total testosterone levels, resulting in increased activity of liver cystathione B synthase, that is CBS. The shift to the transsulfuration pathway of homocysteine metabolism might cause a decrease in serum homocysteine levels. Thus, atorvastatin has a vital effect on improving insulin resistance and hyperandrogenism in PCOS patients. Coming to the second category of lipid-lowering drugs, omega-3 polyunsaturated fatty acids. Omega-3 polyunsaturated fatty acids improve lipid metabolism in PCOS patients, mainly by altering the transcription of peroxisome proliferator activated receptor B, sterol regulatory element binding protein 1, and the carbohydrate regulatory element binding protein, MAX-like factor, and factor X heterodimer. Omega-3 fatty acid naturally activates peroxisome proliferator activated receptors to inhibit the synthesis of lipids in the liver. Peroxisome proliferator activated receptor GAM, that is PPARG, regulates the expression levels of several genes encoding proteins involved in adipocyte differentiation and fatty acid storage. After supplementation with omega-3 fatty acids for 12 weeks, the expression of PPAR gamma gene was significantly improved and low-density lipoprotein receptor LDLR was reduced by inhibition of the phosphatidylinositol 3 kinase and protein kinase B pathway and modulation of the activity of the oxidative stress-induced nuclear factor K gene binding, that is NFKB pathway in PCOS women. Omega-3 fatty acids affect ovarian function, follicle maturation, and the formation of dominant follicles in PCOS patients. EPA, that is eicosapentaenoic acid alone, could result in comparable upregulation of insulin growth-like factor 1 expression in PCOS patients and the combination of recombinant FSH. EPA has been shown to induce a stronger upregulation of IGF-1 than EPA alone. The hirsutism and hormonal profiles such as LH, total testosterone, and free testosterone in serum were improved by increased levels of SHBG after 6 months of omega-3 polyunsaturated fatty acid treatment. The omega-3 fatty acids can improve insulin resistance, inflammation, and hormonal profiles in PCOS, which play an important role in the prevention of type 2 diabetes and chronic inflammation. Nicotinic acid. This is a third drug. Nicotinic acid, known as vitamin B3 or vitamin PP, is involved in lipid metabolism through the conversion to nicotinamide and subsequent inclusion as a component of coenzyme 1 and coenzyme 2. Niacin acid can inhibit triglyceride hydrolysis, reduce the release of non-esterified fatty acids into the liver, and subsequently decrease the hepatic synthesis and release of VLDL triglycerides by binding to nicotinic receptors in adipose tissue. Moreover, nicotinic acid can improve the lipid profile by lowering LDL-C particles and increasing HDLC in the serum of PCOS patients. Current recommendation for lifestyle modification. So ultimately, whatever the pathogenesis, whatever the drugs we are using, the one and only thing which has effect on the dyslipidemia or PCOS as a whole is lifestyle modification. Here, weight loss of 7% of body weight, increased physical activity 150 minutes per week, a 500 to 1000 kilocalories per day decrease from usual diet, 1 to 2 pound weight loss per week, low calorie diet of 1000 to 1200 kilocalories per day, achieving 10% decrease in total body weight over 6 months, reductions in weight of 5 to 10% of initial body weight may reduce the levels of insulin and androgens. Weight gain recurs when lifestyle modifications are not sustained. If you see the picture here, you have to shape yourself. It means we are responsible for our health. Whatever we eat, what are we eating, or what we are supposed to do, or what we are doing, we need to think, we need to re-evaluate all the conditions. Your sleep, your physical activity, your calories, and counting on what kind of fats you are eating, and how much movement is there, how much connectivity is there, and the mind, positivity of your mind to get into shape. All this comes under lifestyle modification. Whatever may be the diet or regime you are following, the sustenance or maintenance of the healthy ideal body weight, we need to pay a price for it. Weight loss, lifestyle modification, dietary restriction, physical activity, pharmacotherapy with varied results. Dietary interventions are associated with increasing weight regain over time, although this can be minimized with continuing care. Only 15% of the subjects can sustain weight loss successfully over time. Rapid weight loss achieved by crash diets or excessive exercise is detrimental to reproductive outcomes during fertility treatments. Lifestyle modification programs, especially diet programs, have been shown to be associated with poor levels of compliance. Coming to the weight loss, lifestyle modification, we need to be educated about the food we are eating. That is it carbohydrate, is it fat, is it fiber, is it vitamins, or it is artificial or natural, or it is local, or it is imported or from different place. And looking onto the seasonal things we are eating. And dietary restriction depends upon what is the thing that is making you weight gain or losing weight. And physical activity, at least 5 days a week, you need to do a minimum of 45 minutes of activity. It should include aerobics for cardiovascular health and weight bearing exercises to maintain the bone weight, and abdominal exercises to reduce abdominal fat. So you need to have a regime of exercise of different varieties, not to get bored, and keep yourself fit. Very low calorie diet resulting in rapid weight loss may have impact on oocyte quality and fertilization rates. Calorie counting is not only the healthy way of losing weight, but it should have the required nutrients for the general health of our body, which in turn has an effect on oocyte quality and fertilization rates in becoming pregnant. Metformin at a dose of 850 milligrams twice daily have not been shown to affect menstrual frequency, body weight, or insulin sensitivity, despite a fall in testosterone and waist circumference. It is said metformin is useful only in obese PCOS patients, and we need to look into any side effects of metformin drug causing gastrointestinal disturbances. Orlistat used to lose weight in obese PCOS, showing a degree of effectiveness. However, there are no large randomized controlled trials in obese subfertile women. Coming to the inositols, myoinositol treatment increases serum plasmalogens and decreases small dense LDL, particularly in hyperlipidemic subjects with metabolic syndrome. Increased plasmalogen biosynthesis and or serum levels are especially effective in improving metabolic syndrome among hyperlipidemic subjects with metabolic syndrome. Screening for cardiovascular risk in PCOS. Cardiovascular disease risk factors include obesity, lack of physical activity, smoking, family history of type 2 diabetes mellitus, dyslipidemia, hypertension, type 2 diabetes mellitus, impaired glucose tolerance. If you see this picture, subclinical cardiovascular disease leading to clinical cardiovascular disease, metabolic syndrome in the middle, which is surrounded by insulin resistance, dyslipidemia, hypertension, hyperandrogenism, obesity. These are all connected in turn leading to cardiovascular disease and cardiovascular risk factors with PCOS in situ. Late reproductive age and menopause. As age increases, insulin resistance, abdominal obesity, adiposity, along with chronic inflammation and dyslipidemia increase. Metabolic abnormalities in women with PCOS worsen with age. Waist circumference, cholesterol, and triglyceride levels increase in women with PCOS as they reach 40 to 50 years. Women with PCOS demonstrated a prevalence of type 2 diabetes mellitus of 39% as compared to 5.8% in the general population in the West. So even the menopause, there are a lot of risk factors which leads to diseases. This is an interesting chart. Polycystic ovarian syndrome leading to obesity. If you see the arrow marks, they are all interconnected. PCOS leading to obesity, obesity leading to PCOS, and both leading to hyperandrogenism. Hyperandrogenism and obesity are interlinked. Obesity and insulin resistance and hyperinsulinemia are interlinked. So this is a you cannot separate one from the other due to the hormonal changes occurring in the PCOS. And cardiometabolic risk factors. Traditional risk factors like central obesity, dyslipidemia, hypertension, impaired glucose tolerance, leading to hyperandrogenism, sympathetic nervous system dysfunction, chronic inflammation, oxidative stress, hemostasis and fibrinolysis imbalance, vitamin D deficiency, mood disorders, gut microbiota dysbiosis, and epigenetic alterations. These are all the cardiometabolic risk factors leading to cardiometabolic diseases, that is premature atherosclerosis due to endothelial dysfunction, intima media thickness, coronary artery calcification, leading to non-alcoholic fatty liver disease, type 2 diabetes mellitus, coronary heart disease, and stroke. So all the systems are involved in PCOS. The combined therapy, myoinositol plus D-chiroinositol in a physiological ratio, reduces the cardiovascular risk by improving the lipid profile in PCOS patients. The combined therapy, myoinositol plus D-chiro, is able to improve the metabolic profile of PCOS women. Therefore, the cardiovascular risk is reduced. Thank you.
Thank you very much, ma'am, for the wonderful presentation. We are very honored and glad to have you, ma'am, for the presentation. Ma'am, if you allow me, then we'll take the questions.
Yeah, sure.
Yeah, sure, ma'am. Ma'am, we have a first question.
Okay.
That is, after having bariatric surgery, how many days should the patient wait to get the pregnant?
Actually, it is said after bariatric surgery, you need to wait for 3 months. Now, the post-operative electrolyte imbalance complications and regarding the environment inside, it takes time. So 3 months is necessary. And during that 3 months, they need folic acid supplementation.
Thank you, ma'am.
Okay.
Ma'am, we have one more question. When to start this statins?
Start or stop?
Start.
Actually, when to start is when there is a high risk history, like premature cardiovascular deaths or premature coronary artery disease, a familial history. It can be used as a preventive drug for prevention of coronary artery disease. It depends on the investigations done, screening lipid profile and ECG to see the heart function. And HbA1c to detect any abnormality in the blood sugars. And also serum uric acid to know whether they are at risk for hypertension. Higher levels of serum uric acid, it is a risk factor for development of hypertension.
Thank you, ma'am. I think there are no more questions from the delegates. If you allow me, then we'll close the webinar.
Okay.
Yeah, thank you very much, ma'am. It was a very nice presentation. We look forward for your continuous support for this educational initiative. And many thanks from the SHIELD team. I also thank Malla Reddy and Saban for organizing. Thank you, ma'am. Thank you very much, and have a nice day.
Thank you
And
so
also-
much for giving me this opportunity. Because I like to know more about PCOS. And so nice of you to give
Sure,
me this
sure, ma'am.
time. Thank you.
It was so nice of you, ma'am. Thank you, ma'am. And I also thank all the delegates for active participation. Have a good.
Thank you.
Thank you.